Okay. Um, Working with communities, I'm just gonna read this to you. The SAMHSA funded Opioid Response Network, or ORN, assists states, tribes, organizations, and individuals by providing the resources and technical assistance they need locally to address the opioid crisis and stimulant use. Technical assistance is available to support the evidence-based prevention, treatment, recovery, and harm reduction of opioid use disorders and stimulant use disorders. If you have any questions or want additional technical assistance, you will receive these slides, and you can always request assistance at website and email. Just a reminder that we us at National Harm Reduction Coalition, we are a separate entity from SAMHSA. So this is a reminder that because we can sometimes when we do trainings, we can have a pretty radical um way of looking at things that can be a little bit more progressive um than we used to. So this is a reminder that what is said in this training and session, this does not mean that that's exactly how SAMHSA sees it. So that's just a reminder. And doing this training and this series, our approach is to build on existing efforts, enhance, refine, and fill in gaps when needed while avoiding duplication and not recreating the wheel. So at the end of the day, we understand that, whether not everything is perfect, but we're just here giving a different perspective, when we do these sessions, so it's not that we want to bring something new, it's just that we acknowledge that what we have now can definitely um use a restructuring. Overall mission is to provide training and technical assistance via local experts um to enhance prevention, harm reduction treatment, especially medications like buprenorphine, naltrexone, and methadone, and recovery efforts across the country, addressing state and local specific needs. We do ask and that we are always open to feedback. You know so if you do have the time after this training, please scan this barcode. And yeah, just tell us what your experience was like. Okay. So what you see in front of you, this is called our North Star statement, our meaning National Harm Reduction Coalition. And it's basically what drives our work. It's like I like telling people it's our work in a nutshell. And it goes, National Harm Reduction Coalition creates space for dialogue and action that helps heal the harms caused by racialized drug policies. And with this, we are acknowledging that a lot, if not all bills passed are made to, keep specific communities and lower places than other communities, specifically, Blacks, Latinos, and people of color, indigenous people also, and at the end of the day, uh equity should be, it should be on the forefront, of our minds, of our conversations, and that's what we strive for when we do our work. We do this by policy and advocacy. Our organization is about maybe 30 people, a little more than 30 people, and we are all advocates in our respective states, advocates and community workers, you know, and yeah, you might, we are always in capital, advocating for different, different bills and laws to be, passed or not passed. And, we also have national and regional conferences. We had one in 2022 um, in Puerto Rico. We do a lot of trainings besides this one. We have our work basically, for the most part, is introducing harm reduction to organizations and, building on that approach. So we do a lot of these trainings and, we're always helping organizations just try to be better. We also help organizations become opioid overdose prevention programs. Some people refer to it as OOPS, but it allows organizations to train and also distribute Narcan and naloxone. And also on our website, we have a lot of resources there that you can utilize. We have a lot of webinars that we've done, a lot of panels on different topics. We also have different training packages, both free and some with cost. So definitely visit our website. Ah, they changed it to ellipsis. Nice. Um, so if you feel comfortable, uh, please add your pronouns to your name because there are going to be moments through this session that we ask folks to come off of mic. And if I'm addressing you, I will want to address you by the pronouns that you want to be addressed as, but you don't have to. That's only if you feel comfortable. Um, so how you do this is on your screen, you go to your where you see yourself and you drag the mouse over the three lines, the ellipsis, um, and you just click it, you scroll down, it says rename, and you could change your name, to whatever you want, add your pronouns there. Just another friendly reminder that, if for the moments that, we aren't speaking, just make sure your mic is muted, just so that, everybody could get as good as experience as they can. You know, um, feel free to use the chat, talk amongst yourselves, ask questions. You know, I I mean, I do these trainings a lot by myself, but I'm not really good at keeping up with the chat. So if questions are asked and I don't really see it, I apologize for that, but I'm gonna try my best to like answer as many questions while also, keep in mind of the time. You know, yeah, tech issues happen. If, anything happens, just come back. We're gonna come right back here. I'm in Buffalo. The internet's choppy out here, so anything can happen, you know, and yeah. So we're going over our overview now. We went through our agenda. How we're going through our agenda. Housekeeping. We're gonna go over housekeeping in a bit. Then we're gonna talk a little bit about opioids. What are they? Their impacts on our body, naloxone, and how it works, how it contributes to the overdose. Not contribute, but helps. Fight the overdose crisis that we've been seeing, and experiencing. We're going to talk about overdose symptoms, how to respond to the overdose, and we're going to talk about prevention tips. Hopefully, I can go through the material and have enough time for people to ask their questions, but as much as possible, I am going to try to like leave space for questions, so, and just foreseeing, future conversations, I do want to apologize beforehand if I do say, hey, we gotta speed through, these slides because we out of time, So, um, but yeah, moving forward. So, um, when we do when we do any of our trainings, when we do any of work that involves community, we're always thinking about harm reduction and, our principles that help us, and, so there's always this discussion and disagreement with harm reduction in general because people believe that we are advocating for people to use drugs, and that is not the case. We are advocating for people not to get treated a specific way because they use drugs. We're advocating for people to acknowledge, just what our, community members go through, reasons why they may be using drugs, and being mindful of drugs, and their effects, um, before approaching, any kind of, judgment. So I do want to start this off with having, a discussion about it, if y'all don't mind. But what have you heard about harm reduction? How familiar are you with harm reduction? And y'all could um come off mute, or y'all could share this in the chat. Either way is okay. It's person centered. Yeah, yeah. What else? Not all at once, everybody. One mic, one mic.
Sorry, one came to me directly, but it says provide test kits.
Test kits that help save lives. Okay. It's compassionate and not punitive. And to answer your question, Vicente, so this is more like a general overview of, like, overdose and stuff, but it was mentioned in the chat, we do have an office hours, and then if there's specific questions that can't be answered on this, I have a parking lot, rule. You can always email me, and if I personally don't know the info, I'll make sure to find someone or something that will get you that info. So best I got right now. It helps saves lives. Did I skip any? It helps, it's person-centered, it helps saves lives, it's compassionate and not punitive, finally allowed by the feds. For real. It acknowledges that there are safer ways to use substances than others, and communities should take action when it comes to overdose prevention and judgment-free connections to life-saving resources. Yeah, yeah. You know, Um, yes, to what everybody said,
Oh, I'm sorry, Charles has his hand up.
Yes, I was about to get to him.
Sorry.
Yes, Charlie.
Good morning. I think for harm reduction, to me, I think my view of it is giving people a tool that they might not have access to, and giving them a little bit of a resource to put themselves in a better position to be a little bit more helping themselves.
Yep. And it also sees the person, and a lot of times, like, and honestly, I grew up with labels, labels initiated by my family members, close friends, neighbors, so, um, I know that, we as humans have a problem with seeing a complete person. It's easy to judge people. So if a person is using drugs, it's easy for somebody to say, oh yeah, that's a person who uses drugs, or no, I don't think that person could maintain a job because they use drugs, or, and really, there's other labels like homeless people, sex workers, people who are part of the LGBT community, that they experience that same thing where, they're nothing else but that label, and this is why I said, like harm reduction, we're not advocating for people to use drugs. That's going to happen regardless whether we advocate for it or not. Let's be honest, what we advocating for is for the leadership and the people in decision making places to look at the individual, to not look at not give somebody limitations because of their circumstances, to actually put them in certain opportunities because they're in that place. Like if somebody's homeless and broke, give them a job, don't keep them from the job, so and this is why it's like, we giving a different perspective. We're not giving, something that is new, is brand new, because this is law that we hold with the people we love, so why we can't give it to people that we don't know, so I want people to look at me as a human being. All my friends today look at me like that, you know, all my family members. And I'm sure we could all say the same thing also, you know. So, and there's a whole community that needs that same exact energy that they not getting or can't get. Before we move on, let me see. Is there anything else? Yep, connection. Um, Acknowledge that addiction is not a morality issue. Harm reduction encourages connection. Yeah. hmm We have a short video. Tell me if y'all hear this.
You ready?
Okay.
Personally, for me, harm reduction is important because I watched my brother use drugs for years and ultimately overdose and die.
Harm reduction is important to me because it means keeping my family safe.
I believe that it also includes therapeutic rather than punitive drug policies.
I have a lot of family drug use, and it was constant fights, bitterness, anger.
I was lucky enough to make it when I had some times of struggle.
In my world, I believe to change someone else's life is to change their narrative.
And with harm reduction, I've learned not to have all that anger, to be more compassionate, to not judge anybody and be so critical.
Harm reduction gave me a sense of family, sense of belonging, you know, a place where I was accepted just as I was, just as I am.
As a physician, I believe in harm reduction because I'm sick and tired of my patients having to die.
I lost my daughter to the disease of addiction.
May all beings be free, and may my work contribute to that freedom.
It's important for you to find your own healing, to find your own path.
It's about civil rights, it's about public health.
Helping people regardless of the choices they make in life.
We don't judge people.
I believe that the people themselves are the experts on their own lives.
My harm reduction truth is that I was a skeptic, and even as a person who injected drugs.
I believe that harm reduction
is a movement that is never gonna stop.
That advocates for human rights, that advocates for humanity, that advocates for being a whole human being and respect.
Harm reduction works because it was created for and by people who use drugs.
It's not a radical idea. None of these concepts that people are complaining about and think are radical. They're life-saving, common sense things.
I believe that harm reduction is the absolute opposite of tough love.
Harm reduction asks us to look at people as full human beings and recognize their full humanity, and that is challenging because we live within systems and structures that every day require us to do the contrary, to stigmatize and to dehumanize people.
When I was looking to build a relationship with my father, there were so many people who told me to forget about it, to wait, and for me, I lost the opportunity.
My boy Kenny, he was only 25 years old, died of an overdose. He was a peer educator just like me.
The truth about harm reduction is that the bigger our movement grows, we run the risk of losing the essence of harm reduction.
My truth about harm reduction is that it is the answer to most of life's problems. The hard part about having that skill and knowing that that's true is actually doing it.
Yeah, I believe that people really do want to be healthy and well.
I believe the war on drugs is a war on people.
Harm reduction has helped me reunite with my family and most importantly with myself.
Harm reduction is part of my life. Harm reduction saved me.
I believe harm reduction is just another way of saying that I care about you.
In my mind, harm reduction is the real thing, and that is love. And that's what I try to do each time I step on the street, to deal in love and safety.
I feel like our community has been so stigmatized and pushed down and pushed out and pushed away that people forget that we're not even just like them, we are them. You know, we are people. We are your neighbor, we are your son, we are your friend from college.
Harm reduction is rehumanizing, harm reduction is love, harm reduction is kindness, harm reduction is helping. Harm reduction isn't about me, it's not just about you, it's about us.
Oh, boy, I always mess up with that one right there. Okay. What do anybody, does anybody have any, what do you think? Any thoughts? Anything that came to mind? Okay. It is a nice video, and it speaks to, what we really are advocating for, and we go ahead, Vicente.
Okay, hey y'all. Yeah, I've been in this field for a few 24 hours. And there was a time where we could not even mention the term harm reduction. Starting with the feds on to the local level. And so being here and having this presentation and hearing all those testimonies, that took less than 2 or 3 seconds about the compassion, the love, the connection that comes out of all of this. This is part of a shift that I'm seeing in treatment and recovery and prevention. There is still an area there that I'm really waiting for, and that is innovation in treatment. This won't take long. As I look at the treatment field, which is, you're looking at 12 steps, about 80 years, and people, addicts, have evolved in that time, where, like, as we know, treating an addict in 2024 is different than treating an addict in 1940. And so I'm looking for innovation and don't know where it is, don't know what it looks like, but I do appreciate that harm reduction is taking us to a place where we can actually care about people with words and deeds. Thank you.
I agree. And just the same way all of them people said, harm reduction changed my life, I'm definitely one of them people, right? And really all people need is an opportunity sometimes, opportunities aren't offered, especially, there's the mentality, you gotta take, what you want, and sometimes, people already beat down, they ain't got the energy to take anything else. So, but a reminder that the people who brought harm reduction, to where it's at, they were regular people. There was people who used drugs, there was people in healthcare, nutritionists, people who had kids who, used drugs, um, and stuff like that. So that knowing that alone kind of like, debunks like this whole myth that people who use drugs, and don't really care about themselves, and people in the homeless community the same, and all of the, marginalized and stigmatized communities, they have the same, kind of like, disrespectful reputation of they don't care about themselves, but these kind of messages show different, these is people who held down jobs, held down families, while doing their thing, and advocating and building harm reduction to where it's at. And, there's a belief that what is good for those who are most marginalized is good for all. Because harm reduction, we basically talk about loving people back to health, just loving people, you know. And in a lot of cases, that's the missing factor. So and harm reduction, like I said, it's not only about, yeah, let people use drugs, but we utilize a spectrum of strategies, to reduce the negative consequences associated with drug use, sex work, and other behavior. So, safer techniques, right? Because maybe sometimes people, it's not their time to stop using drugs yet, because we have to think about a lot of things. If they're sleeping in the street, that drug may be the reason why they keep insane, or we don't know what's really going on in people's lives. And so maybe the proper approach for that moment would be teaching them how to use safely, right? So maybe they've been sharing syringes, or they have been using the same equipments over and over again. Maybe the message is, hey, let me take these, equipments, or let me teach you how to, like, when I first started in harm reduction, I never injected drugs before in my life, but I am an expert in, tying up. I know how to mix up drugs. I know how to articulate that to the community also, and not because I need it, because when stuff hit the fan, I go towards a different route. But it's because that other people need that. When I first started harm reduction, I had someone who's under my support who is 28 years old, um, was using 14 years of his life at that time. That means half of his life. And he never injected himself. Somebody else always did it. That means they also prepared his drug for him also. So there was no telling if that person was using the proper drug they wanted to use, or if it was anything, because you never know where people's mind go. Um, that's when I learned. I had to learn, like, that was the proper message for this person, because the person was not trying to stop using, and that was the harm at that moment. That person, once I taught that person how to tie up the proper way, the 45, inject at a 45-degree angle for the best, insertion, and you lower that number if it's in places like your hands, all of that was necessary for this person. Person came back about a week later, feeling completely good, so happy about it, and I didn't understand why, but it was empowering to the person, to be able to, like, be by themselves, use, not worry about if it's what they got. I mean, if it's what they bought, or if somebody pocketed their stuff. The same thing with, like sex workers. We believe in giving, like, bad date sheets and stuff like that. The whole thing is, we're not pushing nobody to the side. We're not writing nobody off. We're not, no case is too hard, basically. No, there is a loving approach for everybody, and that's the whole point. Thing is that sometimes we have to have realistic conversations with our people too. Let's say we're hiring somebody, right? And their history is for the previous 10 years or 15 years before that moment, they've been using, homeless, have been sleeping in the street, you know, uh, they may come to the job and just, like, may have a certain routine, and sometimes that routine is counterproductive to the job. So we have conversations with people like, hey, um we're not telling people you need to stop, because we don't throw expectations on people like that, but we're saying things like, hey, do you think that for you to keep this job, let's just say for you to keep this job, do you think that amount of drug use is going to be helpful? Is there anything that we can do to help you with, rearranging your routine so that, it fits the job? Because we have to be honest, you know, not everybody is accepting of drug use. And for the most part, actually, organizations don't tolerate drug use, So, but we have to be realistic with, what happens with drugs, and this is what I love about harm reduction, because we're not being naive. We're not being naive saying, you know drugs is good, and we're not being naive at all and saying people who use drugs cannot maintain a healthy lifestyle. And that's all it is. It's having those conversations the right way, not disrespectfully, not judging, and actually including that person so that that person can think for themselves, like, you know what, this is what I can do. Maybe they can use a couple of hours before work, couple of hours after work, or half of their what they use if they have to use during work, but we have to have those conversations respectfully. But abstinence, right? So a lot of people consider harm reduction on the opposite end of the spectrum of abstinence. And maybe that's true, but that don't mean that we don't have that as a tool. The whole thing is that we feel people need options. There's people who thrive under the abstinent-based structure. This is why me personally, I don't deal with rehabs or detoxes. I will find another way if I have to kick a drug, right? But if somebody else comes to me and say, hey, I'm not going to tell them, yeah, no, you don't want to do that, because my experience was, no, I have a lot of people I could call, and I do, So it's a tool, and it helps. Some people need that. But as long as it's what that person wants. So we believe harm reduction, is in harm reduction movement, we believe public health is social justice. Poverty and is definitely linked to lack of resources and stuff. We have to think about that. Racism, stigma, and criminalization can cause harm. The prison system, all it's done is, let our people out when they do let them out in a worse way, where they're traumatized about their experiences, they are institutionalized, and they don't have no independent living skills that's going to be pertinent for the new life they stepping in. The only skills they have is, it helped them survive in the position they was in before. We believe in ending inequality and oppression and fostering health and liberation, and leadership of the most impacted is key to transformative change. We have a model, and these are the principles that we live by. We focus on people's health and dignity. you know, um, we make sure our services are participant centered. If we keep participants involved, we um we build on their autonomy, and we acknowledge social cultural factors, and we're realistic about like drug use and where it comes from and why a person would be using, we would get a lot more done. We cannot expect to, tackle this overdose crisis. We have 100,000 people every year for the past 4 or 5 years. We're not going to tackle that just judging people. We have to look at the whole individual. That means them as a person and the circumstances that they're under. Um, Harm reduction focuses on and maintains participant autonomy, senses participants' needs and wants, focuses on concrete and realistic steps, and acknowledge barriers and it's flexible. The reason why I said concrete realistic steps is because we believe like sometimes the wrong thing for a person to do is to be completely abstinent of whatever, whether it's drinking, using drugs, sex work, you know, sometimes like, people's situation calls for um real specific approaches, and understanding, you know. So let's say let's say a person's destination is the alphabet from A to Z. Do you think that it's better that they go straight from A to Z? Shouldn't they jump through B, C, D, E, F? That's how I see it. It's really simple, very simple to look at. Baby steps, So sometimes that no, you need to be abstinent is a Hulk leap, like the Incredible Hulk, how he jumps, and it's a very big jump. Sometimes in a person's life that's not healthy and is not advisable. Sometimes we have to like, baby step people. So that's what I mean by we focus on concrete and realistic steps. One size does not fit all. Um, remember to consider accessibility and go beyond curiosity. So, if we wondering why a person is using, well, maybe we got to go through the steps to get that knowledge, so that we can have a better understanding of the individual and how best to support the person and capture their lived experience. When we talk about drug use, this is like the best template for me when I'm talking about drug use and understanding it, right? Because even though this looks like a line, and on one end we have no use, and on the other end we have chaotic use and persistent use, meaning that they are using drugs like regularly. That don't mean that that's the steps that they're gonna take. A person, it doesn't mean that they're gonna go from no use to experimental to social. People could be anywhere on this line at any time. I've heard of people kicking decade long heroin addictions in weeks. And I've heard other people who couldn't do it, right? So everybody's different. So that means with knowing and acknowledging that everybody's different, that means that all of our approaches need to be different. Not oh, hey, we're in 2024, time to revise our approaches. We're talking about every single individual. We do not need to approach them the same way. We're not going to really get much done like that. Another really good model for me for understanding drugs, and a person, who is using drugs is the drug setting model. And I love this model because it could be used past drugs. You can take drugs out and you can replace it with anything you want. And it gives you such a good understanding, right? So with drug setting, we're acknowledging with a person who is currently under the influence, right? In order to have a better understanding, we have to understand the drug itself, right? Every drug gives a different reaction. People act differently under different drugs, right? How we say heroin, you might see somebody typically nod it off, you know. They may be slower, slower reflexes, right? Weed, people who smoke weed, you'll see them a little more mellow. People who smoke K2, we know that whatever feeling they had before K2, that feeling is going to get amplified, right? So it's basically having the knowledge of the drug. And then the set is the mindset, that the person brings to the situation. So like a really good example is how I said K2, what they call it synthetic marijuana, but it's not a synthetic marijuana. It's just a plant that's sprayed with chemicals, right? But like I said, a person who's using K2, if they're very happy, that K2 is going to make them extremely happy. But if that person is mad when they're using K2, they're going to get in a problem. I promise you, right? So the mindset means everything. And then and we're going to talk a little bit more about this when we talk about mental overdoses, we say mental health is a big part of overdose factors. So understanding how a person reacts under different drugs or the different situations is really important in understanding the bigger picture, basically. And then the setting, the place, the environment that the person is in or was in while using the drugs. I tell people like this. So if you have somebody with an apartment and you have somebody that's homeless, right? They both are prepping their drug and they're both going to use the same drug, the same amount, right? The person who is homeless is at risk of getting overdosed over that person who is in their apartment, right? For the reason of when they're in their apartment, they have time to mix their drugs, so everything is dissolved, everything is as even as possible. They're not rushing anything, they're not bending their equipment when they're trying to get the drugs out, right? Which is what the person who is homeless will go through because they're constantly looking out for police, they constantly got to be aware of their environment. People don't like them also, right? And then, you know, so when they're in that situation, everything like them mixing the drug won't be even. Maybe it could give like the cookie crumb effect or police, so they may use faster. They don't have an opportunity to what we call test their drug, like a test shot. It's called the test shot, which means they test their drug. So in case they think there's something else in it, they just use a little bit and give themselves a few minutes to feel the drug effect, and then assess if they need to use any more of the drug, or anything. People who are on the street don't have that because they need to get it done as fast as possible because anything can happen at any time. So the mindset is, and the same thing with drinking even, right? Think about the person who's in the bar rather than the person who's at home, right? It's the same thing. The setting means everything when we're talking about drug use, So we're gonna get into the meat and bones of this, which is the, overdose training and stuff, right? So I'm wondering what has been your experience? Has anybody here reversed the overdose before? Seen an overdose or been around it? Have any knowledge of like overdose in general? I'm gonna take that as a no. Um, I've reversed two overdoses in my life, and it was not pretty. Either one of them, So I will say that, and I touch on this a little bit during the presentation, you know, um, everybody has their role, and when I was first getting trained in Narcan, it was 2015. I was working for a syringe service program in the South Bronx, and um, we got trained in groups. So we were assessed. Obviously, everybody had to have been knowledged in how to actually like, take the naloxone, put it into the syringe or the nasal, but we was also judged on cooperation. So that's why it was the group. There was one person responsible for how to communicate with EMS on the phone. There was another person that was to help this individual with rescue breathing. There was another individual that was responsible for keeping the crowd back, right? Um and we had to act that out. That was how we got trained. So everybody's role isn't to do the actual reversing, like the Narcan itself. That's a scary situation, and not everybody, so it's really about being honest with yourself and just, so, and I learned that also. You know, there are people who they're so invested that they feel they got to do everything, when you have to learn how to use your situation, so we call that in New York City emceeing the crowd. So, hey, can somebody call 911 and say this person's unconscious? Does anybody have rescue breathing experience, and stuff like that, so all of that we're taught while we're being trained in Narcan, at that time anyway. So yeah, just to go into, so opioids as a drug derived from the opium plant, right? And different opioids that you might know, the regulated ones are like oxycodone, hydrocodone, the medications. Fentanyl also, is a regulated opioid. Methadone also, and buprenorphine, which, if people don't know, um are medications used for people who have a history of heroin, so they may want to stop using heroin, and it's a program. The doctor prescribes them the medication, and it really helps. Unregulated opioids we may be familiar with is heroin, black tar, and also fentanyl. So I know we see fentanyl on both sides, but the fentanyl that is on the street is not the same fentanyl that you're gonna see coming from a doctor. They're more calculated and more, you know, they did their science with fentanyl, how to use it medically. The fentanyl is not regulated in the street. When we look at drug checking programs and we look at percentages of what drug is in the tested drug bags, there's a difference every time in the percentage of drugs in it. So some bags may have 33% fentanyl, some may have 50, some higher, some lower. So that's why
In
it is
fact, we
not
have somebody,
regulated.
you have your own spot. Oh, yeah. All the
Just be mindful to mute yourselves if y'all not talking. Thanks. What is not an opioid is cocaine, or crack, methamphetamine, benzos, Xanax, Seroquel, alcohol is not an opioid, GHB, ketamines, you know. But the thing is that you may have somebody overdose over these drugs because right now fentanyl is like in everything. Even in drugs that's not opioids, there's a lot of reasons why they may be, and I don't really want to get into them, but you know, it's not that these drugs are being cooked with fentanyl or made with fentanyl, but they just so happen to be in these drugs, maybe because of how they're prepped, and that area is not really being sanitized like that. So just to be mindful of that. So when we're talking about opioids, there's three things that we for the most part, a lot happens under a opioid overdose, um, and just with opioids, and drugs. But you know, I worked in a SSP, and this is stuff that you hear about. SSP is a syringe service program, and this is stuff that you hear constantly with people that use like opioids, heroin, fentanyl, and stuff like that. Right? It affects the digestive system, right? In a sense where it like kind of squeezes out the water, dehydrates folks a little bit. So a lot of the people who we come in contact with, they have constipation issues, and stuff like that. So, and we try to inform those folks as much as possible, drink water, and the reason why we have to inform folks of that is because one, people don't always have access to water. So it's not always on the front of folks' mind, like, oh, let me drink water, you know. Um, but then also, it's not common knowledge, you know. So we want to be, keep folks, as informed as possible, because a lot of overdoses, I want to say, are preventable, even preventable on the side of the individual. If they eat as much as possible and drink as much as possible, it really lowers that risk. This is why we say mental health and physical health is definitely a factor of overdose, right? So, and it's important to drink that water, keep them hydrated. Sometimes also under drug use, you don't really feel the need to drink water, keep yourself hydrated or nutrition. The brain, right? It affects the brain also in the sense of, it goes to the receptors. They do mimic natural endorphins, resulting in a general state of well-being, you know, meaning the happy sense, the happy side of you. They so saying that they affect, that side of things, right? So it also relieves pain, physical, emotion, and psychological, right? So not to say pros and cons, it sounds like we just said it in a pros and cons kind of way, but it's just something that we tell people to be aware of. And then obviously the respiratory system, which at the end of the day is the cause of the overdose. The person's breathing slows down to the point of sometimes not breathing, deprives the body of oxygen, and it can lead to death due to overdose. And it's really important to know these things because, like, and you know, a lot of people don't agree with the overdose prevention center that opened up in Manhattan, but you know, in the first year that they was open, they like did like 800, 900 overdoses, which is amazing, and not one death, you know. And the crazy thing is that out of those numbers, they use naloxone probably like 4 or 5 times. So the naloxone comes with 4 milligrams of naloxone in it. And each of the times that they use naloxone, they use half of that. For every overdose that they did, they use oxygen. So this is so obviously being realistic, every organization doesn't have oxygen tank money, oxygen machine money. But what that did tell me was that there's a whole lot of, ways we need to look at overdoses. We was all under this impression like, hey, the only way to reverse an overdose is with naloxone. And in those cases, those 4 or 5 cases, it was just like really extreme. I don't even know the details, but like the person may have been overdosed a little too long, and for cautionary measures, who knows? But that's what that told me, is that like the breathing, focus on the breathing. So if naloxone's not around and you need to wait some time to get naloxone, if you know rescue breathing, do rescue breathing. I know COVID is a thing now. Yes, you're right. And you have the right to rescue breathe or not. But if we want that person to live, there's things that we can do to prevent that. We tell people use hankies, use cups, whatever. Even the naloxone packages come with mouth guards. That protect anything that comes out of the person mouth to go into yours. So like there's a lot of things to make that situation more safe. So but oxygen was I was like, wow, like when I first read that, it really blew my mind. So because you may hear me 1 minute say Narcan, 1 minute say naloxone, and I go between them both, but naloxone is the actual medication's name, like what actually goes in the person's body. Narcan is the brand name of the naloxone, so where it's being like the manufacturer, basically. So naloxone has no abusive potential, right? You can't develop a tolerance to it. If used on something that doesn't consume opioids, it will not have an impact. And people do not get high from naloxone. Contrary to that, they actually get unhide. I said unhide. But no, right? Naloxone is meant to scoop the drug from the person's brain receptors so the person's not under that influence no more. So it actually does the opposite. Um, so and that information alone debunks like there's been so many people talking about people have naloxone parties and to get high off naloxone and stuff. No, it's not true, like nobody wants to use naloxone, so the two most common naloxone types in San Francisco, yeah, but everywhere, is intramuscular, um, which is the needle, and the nasal. This picture that you see here, the top left, that's the intramuscular one, and then the bottom right is the Narcan that we see today for the most part, which is just like a squeezy thing, a nasal squeezy thing. The nasal spray that you see on the top right, that was the first Narcan that came out, like the first nasal that came out. And it was so crazy to put those together. Like they came to you in pieces. Like you had to assemble it, which was so inconvenient for like if a person's overdosing, you pulling the kit out, you got to pull everything out the box. You got to squeeze the naloxone bottle into the to the plunger piece, and it was just too much. So it's good that we got this nasal thing. But the auto injector, the one that's on the bottom left, that's the FZO. They cost so much. They cost so much. Like it is not effective. It is not effective for tackling overdoses because they cost like $2,000 per pack, which came with one trainer and 4 FZOs. that's trash. You know, like that's not helping. That's you trying to monetize off of people's death. You know, so yeah, you know, like so this is a really good example of um how naloxone affects a individual who's overdosed. So on the left hand side, you got like the opioid, the blue curve thing right there. That is your brain receptor, and the opioid goes in, fills it, right? So naloxone, what it does is it scoops it out, right? And it replaces, as you can see, the naloxone now is now replaced in the brain receptor. So for the next 30 to 90 minutes, right? It ranges depending on who's really training you, right? Some people say an hour, some people say 90 minutes, some people say half an hour. You know, I just keep it in the range, you know. But because everybody's different also. But it keeps it stays as a guard basically. So no matter how much the person uses while the naloxone is in their system, they're not gonna feel it, they're not gonna get high. And this is why we tell people, like, you know, if you know, you are the person responding and you reverse the overdose, tell them not to use drugs because of while Narcan is in their body. Because while when the Narcan's gone, not only is their body gonna have to deal with the drugs that they used while the Narcan was there, but it's also gonna have to deal with the drug that overdosed them. This is why it's important, like, which not it's not realistic, but it's ideal for the individual to go to an emergency room. But not everybody has that, you know, that privilege, you know, whatever the case may be, may have problem with the law, may have mistrust with the medical environment, whatever, you know, but everybody don't have that privilege. But it is definitely recommended that they get to a ER or something, you know, where, you know, they can like get the proper care that they need, you know. So just, you know, be mindful of that. For 30 to 90 minutes, do not use, or else when the naloxone leaves, it's gonna deal with the drug that overdosed you and whatever drug you used. Anybody got questions? Yeah, go ahead, Jasenia.
So I just wanted to see if you can quickly address, we had some questions about xylazine not
Yes.
being responded to naloxone. I know that's probably a question for a lot of folks and just a lot of
Yeah.
the myths around xylazine in general. Thank you.
Okay, let me see what's said in here. My fault, because I talk about xylazine a lot. I do a lot of work with the xylazine wounds and all of that. Um, so was other than what I'm trying to read what was.
It was just about xylazine not responding to naloxone.
Yeah. So here's the thing. Like, so I don't know if you have this study, if you could find it, Jasenia, and share it with people. With the study that Dr. Gupta was talking about, that they they came to find they came to find that xylazine is a copper opioid. So now I am not a doctor, so I can't explain the difference between an opioid and a copper opioid, and that's gonna take some time. But it's an opioid, we're gonna say. Right. So with that being said, that means that it does respond to naloxone. But now here's the thing though, and we've heard this a lot in New York City, even up here in Buffalo, where people's like, you know, it doesn't respond to the naloxone because we're giving them 4 or 5 Narcans and like they still not waking up. Well, xylazine is a sedative. They sleep. So this is what's giving us like a real challenge with this, you know, because okay, you know, like everybody's heart and pulse beats differently. What's the effective way of assessing that situation? What's the proper way? We don't have that yet because even though xylazine is not new, Puerto Rico was dealing with xylazine 20 years ago, 25 years ago, you know, but it's new to us. So it's like a lot of people don't know that it's harmful, you know, when you're using 4 or 5 doses, it's probably work, but they probably sleep. And then what we need to think about is what's the next safe thing to for this individual. You know, this is why, you know, the just language on drug, you know, drug use is important with the individual, because we need the participants and the people in the community experiencing this to share their experiences with us. What it would be the safe way after that. Like, we used 2 doses, right? People, so I don't know if that answers people's question, right? But a lot of people have said that the person didn't respond after they used a few doses, not keeping in mind that the Narcan is used to reverse the overdose effect, not the sleep effect. So with xylazine itself, the vets themselves have a reversal to xylazine, but xylazine is not meant for human consumption. This is why right now people who are using drugs with xylazine are coming up with these big, huge wounds, and that they just look really like it's just really dangerous, you know? And when that same medication is used on horses and, you know, cows and all of those big animals, you don't see those same wounds. So with that said, it's not meant for human consumption, so the wounds come out. So that same reversal will probably have a negative effect on the humans too. So they haven't came out with a reversal to the sleep. Hold on, let me see. Um, I well, can you translate what Madi is saying, Jasenia?
Yeah, she was asking what drug we were talking about. So Mari, oh, that you didn't understand. ¿Por qué no funcionaron? Now I'm saying it in Spanish. That she didn't understand why it wasn't working, why they were saying that naloxone didn't work for trank.
Because, okay, I'm gonna slow it down. So it wasn't that it wasn't working on the trank. The naloxone was working, right? But so it was working on the overdose. Narcan is not meant to reverse sleep. That's what xylazine is. It's a medication that puts animals to sleep, and that's what's mixed in the drug. So when we seeing people like slumped over, there's 2 things. One, we don't even know if they are overdosed. They may be sleep. Narcan is not saying that they are not overdosed, but it's hard to decipher. People now, because we was taught, you see somebody slumped over, they're overdosed, use Narcan. But because that's the effect xylazine has, we don't know if it's working or not. The Narcan doesn't reverse sleep, you know? And that's what xylazine does to the community members using it. It puts them to sleep. So there's been a lot of times and a lot of reports of people saying, I used 4 or 5, 6 doses of Narcan on this individual and they still didn't wake up. And it's like, yeah, because they're asleep. And Narcan is not going to reverse that sleep, you know? So where what I find challenging now when we're talking about xylazine and reversing overdoses is, without violating somebody's private space, like their arm's length space, what is the best way to see if, one, they are even overdosed?
Yep.
Or
Always.
one, if they're overdosed, or two, is it if they are overdosed, did the Narcan work, right? So, and that's the challenging thing about me, you know, and that's the assessment that in New York City we came up with, like, hey, we got to talk about the sleep. How do we address it? You know, and, you know, we even had the conversation of, well, what would be the Narcan of xylazine? And that's how we came to the convo of there's not, the medication is because it's intended for animals, you know, we don't know if it's gonna work on humans. No tests have been done. So yeah. So I'm wondering, you know, because I said something, you know, earlier where I was said, this is why we need to have those relationships with our community members so that they feel trustworthy in us enough to share what their experience is like. Because this is what we need to do in order for us to figure out what's a safe way to address, let's say, a person who we just use Narcan on them, they had xylazine in there, so they're still asleep. What is the next safe way, right? And the only way of the safe approach after that, the only way we could get there is to ask the community members what they've been doing amongst themselves. Because everything that we know about addressing drug use or overdose, how to deal with somebody who had too much cocaine and overamped, and we learned all of that from the community members. Because remember, at one point drug use was stigmatized, so the community had to figure out ways to keep themselves alive and healthy, you know, and stuff like that. um but anyways, this is a good way of, an activity towards that. Well, how would you talk about drugs with a person that you're providing services to? How do you say hi in another language? Hi, like, inebriated. Arrebato no tan jodido. Arrebatado, yeah, yeah. That's all people got spice. It's important because, something that we say when we tell people like how to talk about, drugs with people is, a lot of people, the only way they know how to talk about drugs is from a negative point of view. Like, hey, man, it's deadly, it's dangerous for you. And sometimes that's not good. Sometimes that can make a person not even want to talk to you no more, which is a problem. That alone is a problem in itself. So it's important that we learn how to have neutral conversations about drugs. Like, me, when I'm talking about drugs, even if somebody say they overdosed off of it, if they overdosed off of it, I'm very, as compassionate and sympathetic as I can be, um, but I would never say, that's dangerous, or, stuff like that. I don't use words like deadly. I use words like, that was a strong drug, you know, um, and stuff like that. That way, people don't get the impression that I'm judging them. Because when we use certain words, we don't even know it's subconsciously coming from a point, a place of bias. We think a drug is dangerous, bad, you know, when, yeah, we see overdoses everywhere, but it's not all bad. A part of drug use that people don't talk about is the pros of drug use. Well, why do you think people been using 10, 20 years? Can't be that bad, right? Well, how do you think people was, why do you think people don't mind using for that long? Well, it helps during certain situations. It helps alleviate, certain feelings, calm people down, stuff like that. So we have to have some middle ground. And this is what this this activity helps with. Zooted, tilted, yeah, lean. Yeah, I remember that was the word when I was young. I'm leaning. Twisted. Yo, I'm twisted. Hey, let me stop because now I'm going down memory lane. Let me stop. All right, we're gonna move on. So when identifying opioid overdose, right? Because it's important to know that um opioid overdoses, like from fentanyl, from xylazine, from heroin, they look different than an overdose from somebody using benzos or cocaine. That overdose is called overamping, which is like a person gets overly stimulated. That's what a cocaine overdose does, right? And the methods are different. There's no Narcan for an overdose for, cocaine or meth and stuff like that. There's different methods that we do, like sitting a person down in a dim area, making sure that there's no loud noises, making sure that we are mindful of that individual's water intake, because a person who is overamping, they have no inhibition of water level, of a water cap. So like it's constantly, I need another cup of water, another cup of water. And there's a lot of reports of in emergency rooms of people coming to the emergency room because they don't drink too much water, you know. So overdosing looks different for every drug. But for opioid overdose, if we want to see if it's an overdose, we want to check if they breathing, and we want to see if they are responding. So, and that's another piece that makes um xylazine, like, it makes the whole overdose a little more complicated, because they're sleeping, their breathing are slowed down already on top of the opioid slowing down their breathing, and they won't respond, right? So that's why I'm like, a lot of times that people are reversing those kind of overdoses, a lot of times they don't even know if it's an overdose, you know. um and not saying that anybody's doing anything wrong. I'm not saying that at all. This is a challenge we all are facing, because even me, I've been in this work since 2015. I've reversed 2 overdoses. I've done this training a million times in my life, and today I do not know what a xylazine overdose looks like. I don't know. I cannot look at somebody and tell if they are overdosed, because xylazine, it puts people to sleep. Xylazine is the reason why a lot of people use drugs now also, because it prolongs the use of it prolongs the effect of the fentanyl. So, this is a challenge we all are facing. So no, it's not anybody doing anything wrong. It's oof, we got a whole lot to learn. So let's just say xylazine was out of the picture though, right? If they are breathing, um, and they are responding, then they're just high, and no need for Narcan, you know, and it's not an overdose. So when people are high, their muscles are relaxed. They have slurred speech. They look sleepy. They nod off. The eyes are half open or closed. If they're able to respond to verbal or physical um stimuli. Um, if you're not sure if they're breathing or responding, keep them awake while you ask questions and encourage them to talk. So, in an overdose, they don't respond and you can't wake them up. And this is different ways that we can tell, look at it and see if a person is overdosed, right? Because, like I said, there's like xylazine, for instance. It kind of takes away the look for their breathing and are they responding, right? But that don't mean that because that happened, that's it. They are overdosed, use Narcan. There was one time I was working in a SSP. Actually, this guy was slumped over. He was slumped over. I knew him though. I knew him. I've seen him almost every day. And my other co-workers, they around him, they shaking him and all of that. And they like, yo, I'm about to hit him with Narcan, and I'm like, yo, something tells me he's not overdosed though. Like this is him regularly, give me a second, and I started talking to him. I started rubbing his back. I started squeezing this part of his neck, like not in a really hard way, but it was like a soothing, and I'm like, hey, I'm saying the person's name. I was like, yo, you can hear me? And like after a few seconds of that, like the person like jumps up, yeah, man, like why you bothering me, man? Like, and I'm like, oh, whew. But I knew this person. I saw enough of this person for me to say this person's regular. I don't think we should use, because Narcan is not, even though it saves our people's lives in situation, it is not helpful for our people. you know and this is why there's a reputation about people who get reversed from Narcan, that they wake up angry. No, it's not that they wake up angry. Like, it's just that, once again, drug setting, we have to know the effects of drugs. And if drugs is removed from their body and their body needs that drug, well, there's going to be a little bit of irritation there. Nothing, a conversation is not, it won't help though. You think somebody is going to be mad that you saved their life? No, we have to explain. This is part of it all. We have to explain to them, hey, you just overdosed. I just reversed it, this, and that helps a lot with it. So anyways, so even if that happens, you do what's called the sternum grind, which is rubbing your knuckle like this on their chest to inflict like some kind of, see if they jump. They don't respond to your name, you calling their name. If that happens, then they may be overdosed. Now they have, in their breathing, looking at their breathing, they will have shallow, slow, irregular, or no breathing. So um how EMS in New York City anyway, and I'm sure it's like this in a lot of states. EMS is the ambulance company. They consider one breath every 5 seconds a overdose. Like anything more than that is not an overdose. So this is like a technical number right there. So they also, another thing is, so depending on the person's complexion, it depends what color they become, but if they are overdosed, like a white person or a light-skinned person will come out like a little more bluer, and like, let's say it's a dark skinned or black person, their skin will be like grayish, like silver grayish and stuff, so that's another way we can see like if a person is overdosed. And also the way that they breathe when they overdose, like, a lot of it depends who you talk to about this. A lot of people, the name is different. It may be called the death breath or the death rattle, depends. But it's like it's like something like that, but with more pressure, and you will hear it, like, so that's another thing to listen for also. Just want to be mindful of our time. Yeah. So as I explained before, um hey, do y'all want to take like 5 minutes, like a little eco break or anything like that? What do y'all think? I know I'm giving folks a lot of information and stuff and just talking at folks. Okay. So it's 2:22. Come back at 2:27. So 5 minutes. All right, folks. I want to try to get folks out of here in the next half an hour, so I'm gonna just keep it moving. We have a bit to cover in the next half hour, so. But as I explained before, naloxone is the medication used to. Oh well, is everybody back? Let me stop being fast. I'm gonna be everywhere. Did everybody follow the 5-minute plan? Okay. In good faith, I'm gonna assume everybody's back. So naloxone is the medication used to reverse the effects of an opioid overdose. So it doesn't reverse any other drugs overdose. It's only specific to opioids. So like I've mentioned before, there's no way, people can get, addicted to naloxone or abuse it. It doesn't make people high, it actually does the complete opposite. So, and there's various forms of naloxone. There is the intramuscular, there is the which is the needle that you put it directly in the muscles. There's the nasal that goes up your mouth. And there's something called naltrexone. I forget how exactly is the administration on that. But yeah. So if we heard about fentanyl test strips, I do want to you know, so fentanyl test strips was originally urine test strips. Birth to test it, a pregnancy strip, excuse me. Oh my God, my mind is blanking. Jesus. But people found a way to take pregnancy test strips and use it to test for fentanyl test strips. So that's a nice fun fact for people. Um, but it is used to detect if fentanyl is in the current supply. There's organizations like BTNX and DanceSafe that BTNX sells the fentanyl test strips, and DanceSafe, their organization that they cater to like the nightlife, because a lot of drug use happens in the nightlife and clubs and those kind of environments. So they give them out, in those areas. But overall, and for the places that do sell them, you'll buy them for about $1 a strip, you know. For the most part, most harm reduction organizations have it because that's a really good tool for people who are opioid naive. Meaning that they don't use opioids. The reason why I say it's good for them is because today, 2024, the drug the drug community has changed for a lot of our people. In New York City and in the South Bronx, when I was doing outreach in there, nobody wanted heroin. Everyone wanted fentanyl. There was people who at one point in time was selling straight heroin and nobody wanted it. Like the moment he would say like there's no Fenty in this, people would straight walk away because now people have developed a tolerance for fentanyl, and now that's their choice of drug now. So what was a contaminant in 2014 is now the main drug today. But now there's another contaminant on top of the contaminant, right? So that's what the drug scene looks like today. So it's really easy, and there's also a lot of videos on YouTube that show you how to use fentanyl test strips, but you don't want to dump the actual product in the water. You just you just wasted $10, yo, you know. But you want to take the residue, man, basically, or if you're gonna take from the product itself, it needs to be like a very little amount, like um, but you mix it in, you mix it into the water and you dip the test strip in the water up to the first line and you hold it for 15 seconds. And easy, you leave it there, and one line positive, two line negative. Really easy and straightforward. So, some overdose response steps. The first one is assessment and stimulation. right? So assessment, we want to look, see if the person is overdosed, verbal, physical, and stimulation, you know, um, and that means like I said, the sternum grind, rubbing your knuckle on the middle of their chest about as hard as you could press. That way, like literally you're trying to inflict pain on the person. That way if they not overdose and they just deep in their drug, they coming out of it. And then verbal Narcan, right? Because like I said, this reputation that people have Narcan parties. Narcan is our people's worst enemy. Like you tell somebody, oh, and I've seen this so many times. I don't mean to make a joke out of it, but I've seen so many times like people shake people like, hey, you okay? You okay? Come on, wake up. And they not one response, not one blink, not moving their arm. And the moment they say, I'm a Narcan, they're like, yo, you better not. So I've seen it a lot, but we tell people like scream it out to people, and because no, it's one, it's a waste of money. Two, people also feel uncomfortable when Narcan is used on them, like I said, like there's the chance of their body needing to be under, have drugs in their system and stuff like that. So, anyways, once we figure out if they overdosed or not, if they are, we want to administer the Narcan or call 911. We tell people because it's real complicated. Not everybody keeps Narcan on them, but there's people that do keep Narcan on them. So whatever's closer to you, if your phone is closer to you, call 911. If your Narcan's closer, use the Narcan, and then do it the other way around. We want to do rescue breathing, and honestly, that's if you feel comfortable, but it's really recommended, and reevaluate and or support. So that means like the time after the Narcan, like, does the person want to go to the ER? Do you have the time? And stuff like that. So, like I said, with assessing, and I'm just gonna run through these, slides because we are a little short on time. But like I said, you want to assess, the situation. You want to see if the person is overdosed. You want to do, the screaming their names. I'm gonna use Narcan, and if it don't work, then you want to use the Narcan. So with the nasal Narcan, it comes in a package, and you just peel the back off. It's simple like that. It's like the nose medication for when your nose got runny back in the days and stuff. It's just like that. You use the dose. It comes with 2 doses each naloxone kit. You use one whole dose on one nostril. You want to wait, about 3 to 5 minutes. You got to give the medication time to work. And if the person's still not up, you want to use the other dose of Narcan up their other nose. Like there's a lot of people, I call it panic rescuing, and panic rescuing is really dangerous where, this is why I said the rescue part is not for everybody. Like you have to be calm, you have to be measured, you have to be logical in how you think. There's a lot of people, they so scared they don't want the person to die that they automatically use another dose, and then less than 3 minutes go by, they're like, oh my god, this person's not up, let me use another dose and another dose, and that's dangerous, because the more Narcan you use on a person, now it starts becoming a health issue, like a potential for a health risk and stuff like that. So like you have to be calm, you have to be measured, and now if you do it the right way, 3 to 5 minutes pass after you use the second dose and the person is still not up, and EMS or the ambulance, they gave you an ETA of 10 minutes or 15 minutes or 30 minutes, like, okay, we have to start making decisions, like maybe another dose would work, and stuff like that. But for it all to be a one shot, more than 2 doses, we're putting them in danger. So with the intramuscular now, it's a little more complicated, because, even though, back in the days, the intramuscular was oh, it was the same. I'm thinking of the nasal, excuse me. But you have to, as a little vial, and you have to like carefully because you don't want to like mess the point up and dull it, but you have to like draw all of the naloxone out of the vial in a certain time, you know. But it will be easy because the easiest way to do that, and look, I'm gonna tell you how to do it. And if you ever around intramuscular naloxone, you're gonna do this, you're gonna be like, wow, this was the easiest way. But all you do is pull the plunger all the way back as far as possible. Put the plunger inside of the vial. You put the needle into the vial and you press the plunger all the way down, and it's gonna draw up by itself. The only thing you have to do is tilt the bottom. You know, science. That's science helping us, you know? So science is harm reduction, son. I'm just messing with y'all. But yeah, you know, and you don't want to, it's not like a TB where you put it under the skin. You want to go, you know, like in their thigh, you know. Some people go for the arm. I personally I'm like I don't want to break, like I don't want the needle to hit their bones or anything like that. So I need as much space as I can. So I like the thigh, you know, but not the butt cheek. You don't want to do the butt cheek because, you know, we want it to be effective as possible. So, like I said, whichever one is there first. If the Narcan is closer, you Narcan. If the phone is closer, you call 911. Remember, you don't say somebody is overdosing because they will take their sweet time. You want to say that they're not breathing. So mouth to mouth breathing is crucial because like what an overdose is a person's brain not having oxygen. So they say after 6 to 15 minutes of a person being under an overdose, they are at risk of getting brain damage. And then after that, the risk of death grows. So when a person dies of an overdose, it's because oxygen didn't get to their brain in time. Remember, you can protect yourself with face shields. You know, there's ambi bags also, you know, and also through your shirt, you know, and also the law protects you for whatever limits you set yourself. So like I want to be honest, like I said, like people are valid and being concerned about rescue breathing because of COVID. So many people have died to COVID, and dying from COVID is not an easy death, you know, and stuff like that. So people are valid, and if they say honestly, I don't feel comfortable rescue breathing, I would recommend you do something to replace the rescue breathing, like chest compressions, you know, and stuff like that. So remember, you want to be mindful of your body language. You know, if the person wakes up, you don't under your language. You don't want that person to, you know, feel like they did something wrong. If you know the person, you don't want to say that's, you know, look, I told you it's bad for you or anything like that. You want to be as neutral and as supportive as possible. You want to say, hey, I'm so and so, you know, you were having an overdose and I had to give you Narcan, you know, and here's the thing about it, you know, you let them know you called the ambulance and give them the option to walk away. Because 9 times out of 10, because police ain't stupid, they don't picked up on the, oh, this person is not is not responding. They already know up overdose, and they turn overdoses into crime scenes. So give that person the option to walk away because you don't know where they at in the law, you know, and all of that. You know, I look at people, I don't look at them for their criminal background. My best friends and all of that are real criminals. So I'm very much in tune with the community. So I feel you have to give them that option to walk away. Don't entrap nobody like that. Reevaluate and or support. So if the person, what if the person wants to leave? We let them leave, but we give them the messages that they need to hear. You remind them that they may feel sick, right? Um, Remind them that the naloxone stays active in their body for 90 minutes and they don't want to use during that time. you know, and be mindful of the stigma around drug use and overdose, right? Because anything can happen. You know, I've seen one person reverse an overdose, and no matter how many times he told the person not to use and explained why, the person still went and used. So you may come against some real, just some situations where you like, wow, you know, and at the end of the day, it's really about just being mindful of just drug use, period, and being stigmatizing to the person. You understand? Because we don't know the person's life. We don't know the frame of mind that they in. Once again, everybody has a reason to use drugs, you know? So just saying. Rescue breathing, rescue of the recovery position. So let's say the person doesn't wake up when you give them a dose, and let's say you give them the Narcan and you got to go to another room to go and get your phone. We advise you don't leave them on their back, because there's a possibility they may throw up. And if they throw up while they're on their back, they could choke on their throw up, you know, and stuff like that. So we advise you to put them on their side, as you can see on this picture, exactly like this, where their arm is supporting them on the floor, right? And their other arm is supporting them from tilting onto their face on the floor. It's something like a triangle, you understand? And their other leg, the leg that's pointed towards the ceiling, is more up, like it's up, so that it's also helping keeping the person balanced from rolling over on their face and stuff like that. We want to keep that person like that, because if they do throw up, it'll be come out of the side and fall on the floor, you know, rather than in their mouth and they choke and stuff like that, you know. We want to, obviously, so ideally, I'm going to say, matter of fact, right? Ideally, you know, these is what we want to avoid, because like I said, there may be that time where you got to go and get a Narcan. So you have to leave that person right there, or you have to get your phone or whatever. So the thing about those situations, I call those the necessaries. If it's you have to leave the person alone, cool. Put them in that rescue position, and please be very fast. Back in the days, people put people in baths for and, you know, to reverse an overdose, and they say, oh, it worked then, so it must work now. We advise people not to, because we know Narcan works. We want to avoid giving them anything to drink, because like I said, they may throw up, you know, and stuff like that. Putting ice down their pants does not work. And if they wake up after you give them Narcan, after you put ice in their pants, they're gonna be pissed at you. And don't inject them with nothing but naloxone. You know, nothing, no salt water, no cocaine, no milk. You know, those at this point, you know, we evidence-based, you know, like, and those there's no evidence supporting that those are very effective. You know, there's more evidence saying that it can have, like, you know, adverse effects on them rather than reversing an overdose. Um, so when naloxone substitutes the overdose, a person may experience acute opioid withdrawal, and you may see these symptoms. This is why, like, you know, we have to be mindful of, you know, and acknowledge drug use. Like, if a person's you telling them don't use and they want to use, it's because their body needs it. You understand? And in a lot of times, drug use, the hunger is what controls the person, right? So if a person wakes up, they're in that withdrawal, they feel they need to use, you know what? They're gonna go for it. Whether they have to learn it on their own, they still do it. So I'm just saying. They may have runny nose, sweating, tingling, aches and pains, nausea, can't stay still, jittery, you know, may have pain in their bones, muscle cramps, they may vomit, and may have diarrhea also. So, how to respond to even stronger and unpredictable drugs. So just understanding that, you know, one thing we tell people, like when fentanyl first came out, um, and now we say this with xylazine, we were saying we have to assume fentanyl is in everything now. So when it's in the front of somebody's mind, like, hold on, you know, like there's these drugs that can really kill me, you know, the approach is different. It's like planting a seed, you know, like they'll start being mindful, they'll start test shotting, all of that. The drug community and the drug scene has changed over these last few years. The, like I said, fentanyl was the contaminant. Now it's the drug. And I tell people this regularly. This was less than 10 years ago that fentanyl was the contaminant and what we was telling people to be mindful of. Now we're telling people that about xylazine, and I'm like, 10 years, xylazine is going to be fentanyl and stuff like that. So like this is why we don't need to have like no punitive approaches or no like fear mongering with like the drugs. The only thing we have to do is we need to come together and figure out how to show up for the community, because the drug use is going to happen. Let me tell you that it's going to happen. And if drug use is going to happen, then people are going to try to make more money. So other ways of cutting is going to happen and stuff like that. And it keeps going. So what's the best way? Well, let's focus on trying to make this a safer situation for our community. Okay. All right. So when we talk about overdose, we have a lot of things that we have to keep in mind. Housing, homelessness is at an all-time high in every state, right? Housing definitely is a factor of overdose, because if a person has to take to the streets, sleep outside, their health is at risk, their health and immunity goes down, right? And it creates sickness. Income means a lot also. A lot of people say, oh, a person loses it all because they use drugs. I personally haven't met nobody like that. I've met people who used way more after they became homeless. You understand, to cope with the situation. So that's not to say that, people like, once again, yes, there's negative effects that come from drug use. People do lose jobs because like the drug, is their priority, after a while. Yeah, there's cases like that, but that's not everything. That's not everyone. So, um, yeah. So the drug supply is definitely a risk factor, right? People are under the impression they want one drug, and there's another drug in it that, that's how fentanyl came about. Like our community didn't look for it. It just popped up in the drug supply. There was just overdosing left and right. Social and cultural identity, right? Once again, when you push people, to the side and you write people off, you put people deeper in their hole. This is why we're so big on language when we talk about, when we do like our harm reduction trainings. We like, yo, leave the addict language over there, leave the punitive and break you down to build you up mentality over there. Like we have to show our community love. Our people internalize everything: language, events, TV, music. So knowing that, we have to fill people with loving messages. A person who's been told that they ain't nothing, they addicts, they fiends, and they end up doing good for themselves, and versus a person who's been saying, you've been told you are loved, you are an amazing person. If both them people lose it all, who you think is gonna crawl out that hole first? It ain't gonna be that person who was broken down. I'll tell you like that. It ain't gonna have to, nope. It's gonna be that person who is telling themselves like, you a strong dude. You strong. Like this is just another day in your life. You got this. We need more uplifting messages for our community. That we have 50, 60 years of that break you down talk. Look where we at. you know um Community and support systems, very important. If a person has no support system, hey, that's all they got is themselves. Easy way to overdose. Especially when we say, hey, we need to tell our people about buddy systems, which is, systems they use to notify people they're using, so they could keep an eye on them and they don't end up missing for 2 months. And when they finally found, they rotted. So, so we tell people go slow, period. Fentanyl now is the drug that people are looking for, but there's other contaminants in that drug now. So, and our people know their drugs. So the point of going slow is that when they use a little bit, they know what feeling they're supposed to get. And if it's not the feeling they used to, they can slow down, not use no more until that feeling goes away and figure out what's their next steps. You know? So as a community, we should be centering the voices of people who use drugs and the marginalized folks and people at risk of stigma and, hate and all of that. We want to be increasing access to overdose prevention material and training for people who are giving, providing that support to our community, just so that we can be as on top of our game as possible. And we are working on reframing the narrative and addressing structural violence, and it starts with how we talk with our people and how we talk about drug use, which is in every single community we could think about. You know what I mean? So we have to change how we look at drug use, how we look at certain communities, and we have to come together and put all our eggs in one basket and figure out a way to move forward with it. Different harm reduction resources are really important for our people, so like places where they could get syringes and dispose of their syringes, um, safer drug use supplies, OPCs are really helpful now. We're seeing how many overdoses were reversed, stuff like methadone is really important. If we could find resources like of drop-in centers, that's really good for people who are homeless, because that's the best thing that they can have. Somewhere that they could go to for a few hours, especially if it's raining or snowing, like, so the whole point is just giving our people as many options as possible, because look, the person that's using drugs in the street versus the corporate CEO in a Fortune 500 building, they use the same amount of drugs. There's no difference in the drug use. The difference is, though, is the access to resources. That includes food and nutrition. That includes being able to go somewhere that accepts them, like rehab in NYC, like they crucial to they real beast to our people. They like, no, you already been here last month, come on, there's so much like that, like, so it's the access that's the difference. And that's all our people need is options, so yeah, just some overdose tips. We want to tell people about tolerance. So if they haven't used for a while, they want to use less than they was using before they, took a pause. You want to test your drugs as much as possible. You want to use less and use slow if there's anything that you feel is in your drugs. Try not to use alone or have like a buddy system. Be mindful of mixing drugs. So if they drinking and using opioids, you want to tell them to inject the drug first and assess how they feel. And if they feel good, then go about, drinking or whatever. But if not, then, pausing, having the naloxone at hand and, make a plan. So this is the end of this, and we're going to end with a quiz. I want to see who's been listening. All right. So the first one is, which of these drugs is not an opioid? See? Oh, okay. All right. All right. All right. Let's see. What is the signs that someone is overdosing? You got A, G, D, C, G. Yeah, all right, but it's G. All of them. Is yeah, you these are all different things to look at, to see if someone is overdosing. Which of these can increase the risk of fatal overdose? Um, oh, I ain't say nothing about winning chess. Winning chess is um when a person overdoses from fentanyl specifically. Fentanyl was really challenging people when it first came out because, you know, part of like reversing the overdose besides rescue breathing was chest compressions, and people wouldn't be able to give a person overdose on fentanyl chest compressions because it would stiffen up their chest really hard, you know, and stuff like that. So that's where the name came from and stuff. So, and then they also in the same sense, like their facial muscles would clench and tighten, so it was really hard to open a person's mouth for like rescue breathing. So people was like, oh, we got to do chest compressions, and then came to find out they can't do chest compressions either. So yeah, that's wooden chest. um so which of these can increase the risk of fatal overdose? Is that what everybody was saying? F, yeah, F. Yeah, y'all right, it's F. It's F. Okay, let me see. Which is false? Naloxone can reverse an opioid overdose. Naloxone is legal to use. Naloxone can make someone high, or naloxone can save a life. That's right. That's right, man. Like, look, 100%, 100%. Really good. Um, that is the end of our presentation. And you know, if there's any questions y'all have or concerns, you know, y'all more than welcome to, like, you know, come off mute, and I'll answer whatever questions I can. Yeah, we'll get these slides, and reminder that there's an evaluation and stuff, and the link is on the slides also. So when you get the chance, just, you know, do that also. But yeah. Okay. So any questions, any comments, or
I just want to say we have one more of these trainings next Thursday, and then the week after that, there's an office hours, which is open for anyone to join and just talk through some of the things that we've gone over today, as well as any of the other trainings y'all have attended. So we hope to see you guys there.
yeah, me and Taylor will be facilitating that one. So I'm excited about that. But yeah, y'all be safe, everyone.